Good morning, friends. Uh, Today's lecture is uh, focused on understanding of carcinoma cervix by clinical oncologist approach. Myself, Major Dr. M. Kubeg, radiation oncologist at JK Cancer Institute, Kanpur. So, cervical carcinoma, so far epidemiology is concerned, it has superseded the basically, it has been, breast cancer has superseded the cervical cancer. So far as the woman cancer is concerned, the breast cancer remains above the 100 uh, per lakh population in India. And so far as carcinoma cervix is concerned, it came down to approximately 96 per lakh women in India. So the carcinoma cervix in a gynecological cancer, in a woman cancer, is rated to be second so far as epidemiology is concerned, and that is the latest data report by the uh, ICMR, and by two different registries. The one is the hospital-based registry, one is the population-based registry. We have a 27 centers at the population-based cancer registries in India, but by ISMR, they have further ramified it into the hospital-based registries. So the data collected by these registries are very authentic data that says the breast cancer is basically is more commoner than the cervical cancer. The common symptoms in the breast cancer is pelvic pain, bleeding, vaginal discharge, bowel and bladder issues, back pain, leg swelling. These are the common symptoms do occur. So that we will be focusing on the basically the treatment of cervical carcinoma right from the beginning as a dysplasia or SIN, intraepithelial neoplasia, up to the frank locally advanced cervical carcinoma. So grade 1 is caused usually by the inflammatory infection and should be treated with the patient on a follow-up 3-monthly pap smear examination in case of a SIN grade 1. But a SIN grade 2 and a grade 3 require a locally destructive methods like to treat cryosurgery, fulguration, laser ablation, and excision of local tissues like conization, laser conization, large loop excision of transformation zone. And the third and the last resort is a therapeutic conization or a hysterectomy. These are the, you can see in the colposcopic examination, the cervical cancer is appearing large, bulky at the tip of the cervix, involving more towards the posterior tip of a cervix than anterior. And this is the method of a conization surgery that we required, that the way we required to do it. So the treatment of carcinoma cervix, pre-invasive disease, cryosurgery, laser treatment, and etc. Is now on the back corner. Why it is there? Because before above treatment, one must exclude the following problems. First, the entire transformation zone should be visualized colposcopically, and endocervical curettage should be negative. And then you go for a locally invasive method. Why? Because it might be the lesion may be infiltrating and might be infiltrative carcinoma cervix early stage. Those other sites seen on the colposcopic examination, if negative, a patient, if do not meet above 3 criteria, the therapeutic conization should be performed. So nowadays, I repeat the same things. So nowadays, cryosurgery, laser treatment, Large loop excision of transformation zone is being declined. Why? Because we prefer long follow-up with a pap smear examination for low-grade dysplasia and SIN1, and a high-grade dysplasia of SIN2, SIN3 warrants therapeutic conization to permit the histopathological examination, basically to rule out the invasive carcinoma. And that's sometime entity countered the adenocarcinoma in situ, dysplasia and carcinoma in situ there, adenocarcinoma variety, because we know the adenocarcinoma in situ frequently multifocal, thus cone biopsy margins are not reliable. Thus, ideal treatment of adenocarcinoma C2 is type 1 hysterectomy, knowing the fact that adenocarcinoma also a radio-resistant tumor. So this is a picture which you see the entire transformation zone in a lining is removed, the stitching is done. This is a typical conization procedure is depicted here in this photograph. So now I'll be talking about the invasive carcinomas, cervix. There is a lot of changes is being made in the cervical cancer of FIGO staging in 2018 at Dubai and then accepted by UICC. So the current staging, uh, what uh, is being made in the staging that first of all the horizontal spread is being removed that we used to in the stage 1 the horizontal spread of 7 millimeter. It has been removed. It is found there is no prognostic significance of this. The second one, the 1B is further divided in 1B1, 1B2, 1B3. 1 B1, B2, B3 is divided on the basis that the 1B1 is depth of invasion 0.5 millimeter up to 2 centimeter, and 1B2 is 2 to 4 centimeter, and a lesion is more than 4 centimeter 1B3. What was the compelling reason to further divide 1B1 into 1B2? It has been seen that the 2 centimeter margin, 2 centimeter tissue up to 0.5 to 2 centimeter tissue, the fertility sparing surgery, conization surgery in a young woman has been found if a tumor is less than 2 centimeter, recurrence rate is significantly lower than the tumor if tumor is 2 to 4 centimeter in size. So that propels the gynecologist and gyneco-oncologist to divide the 1B into 1B1, 1B2, B3. Stage 3 is divided into stage 3A and B, and further added with a stage 3C. What was the stage 3? Based on the para-aortic and pelvic lymph node involvement. Is stage 3 C1, is stage 3 C2. If C1 means a pelvic lymph node involvement, if C2 means the para-aortic lymph node involvement. And this involvement is being investigated by radiological staging or a pathological staging. Then you can use the subscript P or small r accordingly. The presence of pelvic para-aortic lymph node assigns the case to stage 3 regardless of other finding, because if a person is cervical cancer is just merely 2 centimeter and having a para-aortic lymph node, straight away the patient is in stage 3C2. That is the this thing, because they have seen the prognosis is quite poor in the para-aortic lymph node involvement. Further also they have said there is no clear-cut demarcation, then a stage-wise proctoscopy, sigmoidoscopy, IVP should be done as per the stage of a patient. Now it's depend upon the given liberty to the treating physician or surgeon to take the investigation according to his and her choice. So the management, the pre-treatment evaluation, what we do, the complete physical and pelvic examination under general anesthesia if required, chest X-ray, IVPs, colposcopy, directed biopsy or cone biopsy, endocervical curettage, and then a biopsy. Optional, no longer an optional investigation. The CT scan, abdomen, and a pelvic from primary tumor as well as lymph node status, distant metastasis, to rule out distant metastasis. Bone scan is if required. So these are the investigation. What was the limitation of just merely doing a PV examination does not, just doing a biopsy examination does not reveal a lot of things in the carcinoma cervix, because you cannot see the punch biopsy report. You won't be able to investigate, know about the depth of invasion, presence of, I mean, a biopsy, you can just see the invasion or presence of lymphovascular invasion. But the local examination, the pelvic wall involvement, anterior and posterior fornix obliteration, these PV examination will reveal. It is vital for a carcinoma cervix to go for a PV examination. And ideally, it should be done in the general anesthesia that provides a better inspection of upper vagina, cervix, and more precise palpation of parametrial tissues and lateral pelvic wall. So, according to the stage, therapeutic conization, type 1 hysterectomy, or ICRT, stage 1, either you go for therapeutic conization or you can go for a brachytherapy, singly use of a brachytherapy. You can do uh, um, ICRT 60 gray to 70 gray alone for a treatment of stage 1 carcinoma cervix. Stage 1A, 1. And A2, since the percentage of lymph node goes high in the pelvic lymph node, despite that, the radical hysterectomy and pelvic lymph node dissection is done, or you can also further goes to the ICRT if medical contraindication of surgery is there, ICRT alone 60 to 70 gray. Stage 1B1. Stage 1B1, this is a very tricky stage. The EBRT plus ICRT combined, or a radical hysterectomy with pelvic lymph node dissection. In both the modality of treatment, the result with the surgery normality individually gives 85% 5-year overall survival. So both are equally good. But whom to would preferred in whom? Surgery is preferred in a young woman with small volume disease, node negative, a very favorable candidate for surgery in order to preserve the ovarian function and maintain the adequate vaginal length. And radiation is preferred in stage 1B1, particularly in the old age women, to avoid morbidity of surgery. And in this stage, the ovarian preservation is also not warranted. This is the teletherapy cobalt machine. We practiced external beam radiotherapy. It's installed in the KGMC way back 2003 to 2006. So the planning for is concerned that you should, and broadly speaking, we take the margin L4 vertebra, L4, L5 junction to the floor of obturator foramen and laterally by the true pelvic brim 1.5 centimeter lateral. That is the AP margin. And then the lateral margin, the cervical curve should be taken in order to include the paracervical, precervical lymph nodes, and also the anterior margin lies 1 centimeter anterior to pubic symphysis, which can see this bone simulator. Sometimes use of midline block is also practiced after the 40 gray. What was the advantage of using midline block? The advantage was that you can go for a parametrial boost, a 10 gray 5 fraction by external beam radiotherapy. And then also midline block using provide extra dose to the bladder and rectum, which is a more dose limiting organs, critical organs so far as a carcinoma cervix radiotherapy is concerned. And brachytherapy dose can be escalated by the use of midline block. But there was a disadvantage of a midline block, that the medial structures like dose to the point A increased, and underdosing to the uterosacral ligament, if disease present there, it might left. So the radiotherapy is, so far as the radiotherapy is concerned, the therapeutic dose to control the carcinoma cervix is 80 to 85 gray to point A and 50 to 55 gray to point B. A radiation given in a phase 1 by the external beam radiotherapy by cobalt or a LINAC, the 50 gray into the 5 fraction to the whole pelvis, the margin I've told, where the boundaries of the radiation portrayal, and a phase 2, since you have delivered 50 gray, I've told you 85 gray is required to be given, so that leftover 30 gray to be given to point A by phase A, by phase 2 radiotherapy by brachytherapy precisely. The clearance of a point A, a point B must be done. The phase 1 external beam radiotherapy like V and cobalt 60, 50 gray to the 5 fraction at the rate of 200 centigrade per fraction, 5 fraction per week, and a phase 2 ICRT or sorbo 30 to 35 gray to point A. This 30 to 35 gray is basically LDR, but we usually now practice the HDR, then the dose correction, the 60% dose is reduced, the so that it comes around 18 gray, so 9 gray into 2 fraction can be given with HDR treatment or by the LDR 30 to 35 gray. But nowadays, because of paucity of time and then inconvenience to the patient, we usually do not practice the basically the I mean low dose radiotherapy LDR treatment. So 1 week time is basically given in the rest, because entire treatment has to be completed within the 7 to 8 weeks time. So this is a lady which is having which is getting LDR treatment after the external beam radiotherapy. You see the 3 applicators, and then the source drum and the bladder. Foley's catheterization of a bladder is done. So in stage 2A, the lesion having a chances of pelvic lymph node recurrence, thus the ideal treatment, surgery along with the post-op radiotherapy. Why you practice post-op radiotherapy? Because of pelvic lymph node involvement, positive margin, residual D, lymphovascular invasion, high-grade histology, parametrial invasion. There's several factors is there. Not only the one factor that's to remove the tumor. Suppose you lift the few of the obturator lymph nodes or some hypogastric lymph nodes, the chances of recurrence. So the stage 1B2 or 2A, both the things, surgery and post-op radiotherapy is to be given. And regarding the stage 2B, 3, 4A, treatment is radical radiotherapy with concurrent chemotherapy, because parametrium once involved, the surgeons don't get a clear-cut margin to resect. So it is better to give a concurrent CTRT treatment, and preferred energy for this thing, like for carcinoma cervix planning, is 15 to 18 megavoltage photon. Why it is clear? Because to spare the soft tissue and skin, and by soft tissue because of thick structures, cervix is lying more centrally placed here, and then the thick abdominal wall, and then posterior side, the gluteal muscles. So the high energy is basically required. Low energy will require is not recommended basically. But if high energy photon is not available, if you are practicing a cobalt, then ideally we should use all the time four field box technique with a low energy to avoid extra radiation, and beam is because beam is less penetrating. That is the answer. So you can see here in the image the point A and point B lies 2 centimeter above the wide, and then 2 centimeter lateral to the center of the uterine canal. And the point A is the area of a paracervical triangle where uterine artery crosses the ureter, and in the same plane 3 centimeter away towards the lateral pelvic wall is the point B. So ICRT 30 to 35 gray plus EBRT 50 gray is a complete treatment for advanced stage carcinoma cervix, and conference cisplatin 35 milligram per meter square weekly is added as a proof that it decreased the recurrence rate as much as 50%. And furthermore, the para-aortic lymph node omission is done because of advent of concurrent cisplatin weekly. We will also take care of the systemic portion of the para-aortic lymph node. In the both the pictures here, in the down the screen, you can see how we find out the vaginal reference, bladder reference point, and the rectal reference point, and also lymphatic trapezoid uh, structures, basically to assess the dose deposition of the different area. The stage, and then here you see the right pelvic wall and left pelvic wall and the tangential line passing and on the head of the femur, and the one from the vertically placed line, and then a cross line area to the line where it crosses the right pelvic wall, and then on the right side on the left side accordingly. So far as the stage 4 is concerned, the patient with a bladder fistula and radical artery is contraindicated. And surgery, basically ideal treatment is anterior exentration or a palliative RT. You can go for 30 gray 10 fraction. And a patient with a rectal fistula, radiotherapy again contraindicated and required posterior exentration, too much mutilating surgery in this carcinoma cervix. And if both bladder and rectal fistula is there, then you have to go for a total pelvic examination. So these are the type of hysterectomy which I'll not be going into detail because it's not my clinical oncologist cup of tea. Just know the type 1 hysterectomy, extrafacial hysterectomy involve removal of uterus, cervix, adjacent cervical tissue along with a small cup of upper vagina, and usually done in the early stage, very early stage, stage 1A1 or stage 1A2 carcinoma cervix. And the type 2 hysterectomy is also called modified radical hysterectomy, involve removal of cervix, uterus, paracervical tissues, uterosacral ligament. The most commonly practiced is type 3 hysterectomy, Verdines hysterectomy, involves removal of complete uterus, cervix, upper half of vagina, and round ligament as well as the pelvic lymph node. Uterine vessels is ligated at the time they at the origin at their origin from the internal iliac artery, so that protects the uh, hazards of bladder fistula by sparing the superior vesical artery. Uterosacral ligament during the Verdine hysterectomy should be resected as much as possible. And Verdine hysterectomy, you can see the indication stage 1B1, 1B2, 2A, early, very early 2B lesion. And anterior exentration and posterior exentration I have told you the tube mutilating surgery has a very high complication rate, but it is recommended in the patient with the bladder fistula or the patient having the rectal fistula. Uh, I mean, in the anterior exenteration patient, urinary conduit is made attached to the ileal segment, and the posterior exenteration patient left with a permanent colostomy. And these are the surgical hazards. High complication rate with the supraradical hysterectomy sees a bowel fistula obstruction seen as much as in a 50% cases. But you must see the contraindication of pelvic exenteration, distant meds, growth involving the lateral pelvic wall, poor general condition of patient. You cannot afford to go for that kind of mutilating surgery. The recurrence after the radical surgery in the early stage carcinoma, when the radiotherapy is not recommended, if a PAP, but a patient is on the follow-up, if a pap smear become positive after 3 months of surgery or a new mass lesion develop at the vault, then it is a recurrence. Certainly, the treatment is radical RT, radical radiotherapy. A patient with a pelvic wall recurrence show poor outcome and compared to the patient who's having a central recurrence. Sometimes after the radical radiotherapy, advanced stage carcinoma cervix is given, and you clinically see the leg edema, sciatic pain, and ureteric obstruction. If any of these features are present, then you must rest assured that these lesions are the carcinoma cervix is not deemed suitable for the surgery. The follow-up after the treatment is recommended by joint jointly by gynecologist and radiation oncologist as per the guideline, and monthly follow-up after the treatment for 3 months, 3 monthly up to first year, 4 monthly up to third year, 6 monthly up to 2 to 5 years, and 5 year onwards yearly follow-up lifelong for the carcinoma cervix patient is required. Thank you very much. Wish you good.